Dr. Sunil Kuboni, Dr. Rajinder Bansal, Dr. Sunil Katyal.
Good morning, everyone. Welcome to this session about downside ECMO. It is a neurological complications. The first talk is on neurological complications in severely hypoxic and hypercapnic patients at ECMO initiation. And this talk is Dr. Padan. I'm sure the people sitting in this auditorium know him very well. He is a critical care medicine physician, Children's Healthcare at Atlanta, and a professor of pediatrics in the Division of Pediatrics Critical Care Medicine at Emory University School of Medicine. Welcome, sir.
Thank you very much, and I appreciate the opportunity to talk here today. You know, the topic of this whole session is about complications. And Graham earlier mentioned something about trying to find cutoffs for who would most benefit from ECMO. And when we think about that and why we don't use ECMO on everyone, it's really because of the complications that go along with it. And so figuring out who is at highest risk for these complications, how we can mitigate them, is really a big portion of pushing ECMO itself forward. So I am going to talk today about neurologic complications after ECMO initiation, and we'll go for that. The one comment I would make is that I feel a bit foolish in doing this, in that I have Lakshmi Raman, who's sitting down here, who's probably a world expert in this and should probably be giving this talk instead of me. So I will give the talk and she can correct me at the end when I'm done. I do want to go through and look in terms of two disclosures in talking about this, and because they're really important in looking through the literature. And the first one is a historical perspective. So if we look at the ELSO registry data, this is the main form from 2010. You see at the bottom there, we've got about 43,000 patients in the ELSO registry at that point. And when you look at the adult component out of that, you've got a total of, what is that, about 3,500 adults there. So that's July of 2010. Fast forward now to 2022, we're up to 172,000 patients in the ELSO registry, and that 3,500 adults is now close to 65,000, right? And so when we're talking and going through the literature and looking at neurological complications, we have to realize that if we're looking at any data that is more than about 5 or 10 years old, most of what you're going to see is reflective of our pediatric and neonatal population. Anything you see in the last 5 years is much more likely going to be adult related. And the other part about that is it's important to realize this massive influx of adults that we've seen have really only been over the past 10 years. And so this is very much an evolving and learning field that we're going through. So the second disclosure I'd make is there's no way to actually talk about all of the things that we would need to in 15 minutes. However, but if you wanted to spend 15 days, you can find charts like this that go through and tell you these are all of the important studies in neurologic outcomes that have been done. Again, because this is an evolving field, there simply aren't that many of them. And you could read all of those in 15 days. If you want to truly be an expert in this, in 15 months, you can go, and this is looking at PubMed and when citations have happened. The highest peak of that you're seeing there is 54 articles in a year. So there are really only about 200 to 300 articles that have ever been written on this. Okay, and so again, very much an evolving field. Now, most of us here don't have time to actually go and read all of those articles. So if you take one thing out of this presentation, it's this slide. These are two very nice, relatively recently published reviews on brain injury and neuromonitoring during ECMO, and are very much, I would refer you to them for a good summary of the topic. So we're going to go through and talk about the kind of who, what, where, when, and why of brain injury and neuromonitoring during ECMO. The other thing that I think is really important to think about is the patients we're all taking care of are different. You may have, a 56-year-old with ARDS who has more hypoxemia than he has hypercarbia. I see a lot of adolescents with severe asthma, with PCO2s that are very, very high, but they're not actually that hypoxic. And then you've got all the way from, again, a 56-year-old down to that 1 day old who's got a right CDH with a very high PCO2, but a very high PCO2 for very different reasons than our normal ARDS patient. We need to be thoughtful about that when we're thinking and going through this and thinking about what the risk factors are. And so who really are the at-risk populations when we're talking about it? Well, some folks came together and looked at the ELSO registry to come up with what are the risk factors for patients having ischemic and hemorrhagic stroke. And in this, it's talking about specifically VV ECMO. And when you look through, you can see they come up with different things that end up being significant, including viral pneumonias seem to be more worse. And then an interesting one to look at here is asthma in terms of ischemic stroke seem to be more common in that population. And we'll talk a bit more why about that later in the talk. We also find that neurologic complications are more common in patients that are having other complications, which again, I don't think is surprising to many in this audience. But when you look through in a registry review, you can find links to or associations to many of these other things that we see. So if we talk about what are we going to measure and what are we going to monitor, you can go through the literature and find all sorts of papers that are similar to this one that'll talk about the feasibility of doing some sort of neuromonitoring in patients. I pulled one here on kids. There are very similar ones in adults. And you can find this for all of the different modalities, whether it's head ultrasound or EEG or things that are much more complex than that. And so it's not that can you do it? They can easily be done, but it's what should we be monitoring? And so there also has a new guideline that you see the title of and the authors of here that is coming out. And this is specifically for neonatal and pediatric patients, but it's talking about what should our routine neuromonitoring be on these patients. I said when I made this talk last week, I said it should be out on the ASIA website. And Lakshmi told me just as I was getting ready to get up here, it got published within the last 2 days. So you can now find this available for you on the ASIA website. To kind of skip to the end, and there's a very nice chart that's in there that talks about all of the different ways that we can do neuromonitoring for patients, whether it's head ultrasounds, continuous EEG, cerebral co-oximetry, NIRS, head CTs, and then the other brain injury biomarkers, pupillometry, and other things you can see there. Each one of these things in and of itself could be a talk. So again, we're not going to have time to go through them. While this is, in this guideline is set up specifically for neonates and pediatrics, we really need something similar in the adult world as well. And one thing that I would mention about this is, while we can monitor all of these things, again, because this is a new field, interpretation of some of these things can be hard. So Sungmin Cho, again, I'm moving back to the adult world now, has published this very interesting paper talking about neurophysiologic findings for brain injury patients in ECMO. And one of the things that they came up with is Things that seem to work very well in the non-ECMO patient in the adult world. In this case, it was looking at SSEPs. Seem to not necessarily be predictive in your ECMO population. And so the interpretation of this was them advising caution in these ECMO patients and in looking at their outcomes and looking at these patterns. Because again, I just emphasize this is something new and is something we're learning about. And as Niels Bohr, the famous physicist, said, the prediction is very difficult, especially if it's about the future. So when should we start looking at neuromonitoring and looking for brain injury in these patients? And the real answer is from the time of cannulation. You have to start this early. And as one example, and there are many in the literature, but as one example of this, let's just look at carbon dioxide and arterial carbon dioxide levels in patients that are on ECMO. And so again, Sungmin Cho and his group looked at this and looked at the rates of, in this case, intracranial hemorrhage that they saw and what that relationship was to changes in CO2 right after you go on. And as you see there in the chart, the odds ratios for both being hypercapnic before you're cannulated, as well as then your change in CO2 right after you go on, were big predictors of whether or not you would end up with an intracranial hemorrhage. And so, again, going to this rate of change that we see when you're looking at, there seems to be a dose effect relationship between how fast you're pulling down your CO2 and your risk of hemorrhage, with the highest rate of hemorrhages being seen in about a quarter of patients that have a greater than 30% drop in their CO2. So that's carbon dioxide only, and those are things that you're going to need to change in those immediate time period right after the patient is going on. There was another look that looked at this and looked at not only carbon dioxide changes, but also what the blood pressure changes are in children, and we're looking at ELSO data. And they found very similar things when it came down to carbon dioxide, that the more you pull it down and the faster you pull it down, the more likely you are to end up with brain injury. But the other thing that they found is that blood pressure and blood pressure management was very much a secondary part of that as well. And so in their adjusted multivariate model, a decrease in PCO2 greater than 30% was independently associated with neurologic complications, just like we saw in the adults. And that then within that group, changes in blood pressure there as well were related to neurologic complications. And so both CO2 and blood pressure control really seems to matter. In terms of moving on to not just detecting these things, but seeing how the patients actually do, outcome monitoring is a big piece of this. And again, Sungmin Cho's group, who's done a lot of this work in adults, talked about neuromonitoring. And they compared an early era where they weren't doing standardized monitoring to a later area where they had standardized their procedures. And so the first thing that you see is you definitely have an increase in the amount of acute brain injury being diagnosed. And so I think that makes sense to all of us, that if I start looking and focusing on something, I'm probably going to find more of it. And so that in and of itself is not bad. The impressive part is the bottom part, which is the good neurologic outcome achieved. And so, yes, they were finding more, but more of these patients, by focusing on their neuromonitoring, were actually doing better long term. And so follow-up for these patients becomes really essential. So I've shown you here, these are the guidelines that we have for follow-up of neonatal and pediatric ECMO patients. And in these follow-up guidelines is a really nice table that kind of talks about the importance of why you need to do this and why you need to follow. And it talks about all of the different stages before they're going on ECMO, through their ECMO course, and afterwards, and looking at how that neuroprotection can be achieved through all of this to ultimately have these folks go on and do well long term. I'm showing you something here for kids, but this obviously equally applies to adults. Also provide you a bunch of tools yourself that you can go and benchmark your own specific center outcomes with the rest of your region or the world. So I want to end this talk by talking and giving you an analogy of something in the future. What I'm about to tell you is not science. I'm just trying to get you interested and understanding about where we may be able to go for this. So there's this famous quote from Neil Armstrong about science has not mastered prophecy. We predict too much for the next year, but far too little for the next 10. I want you to think about what we have done in the heart world over time, specifically with cardioplegia. We know that reperfusion injury is awful, and it's same with reperfusion injury to the brain. And when we look at cardioplegia development over time, we see that what the needs are in a pediatric heart are different from those than an adult. And we've gone and taken the time to do that. Over the last 50 years, we've taken cardioplegia and been able to really isolate the different parts of it in step-by-step fashion, reduce that kind of reperfusion injury. What about, and we find all the different pathways that are involved and be able to do that. But what if we could do something similar for the brain? Think about ECPR, for example. We use the same prime that we use on anything else. Could we take the similar concept of all of these cardioplegia solutions that are protective and be able to develop a prime that would allow us to be able to save folks' brains long term? So again, huge changes later on. I'll conclude by saying again, it's a new and developing field. We've got lots of people who are having success for this around the world. Please reach out if we can help us. Thank you again for letting me speak.
Thanks, Matt, for addressing this difficult topic and giving us a solution, showing us a solution to move forward, and to Lakshmi too. It's my pleasure to introduce Marlies. Marlies has been a good friend from South Africa. She is practicing as a specialist anesthetist and intensivist. Her interests are in critical care, and she is the director of ELSO accredited ECMO Center at Netcare Unitas Hospital in hospital. In 2020, she hosted the SWACELSO conference in South Africa, and she looked after us very well. Her publications are on the use of CRRT in ECMO patients, physiotherapy for ECMO patients and critical care, polyneuropathy, and insulin therapy in intensive care. I invite Marlies to talk on major bleeding during long ECMO. Is it inevitable? Over to you, Marlies.
So I'm very privileged to be here. So this is where I work, Unitas Hospital in Centurion in Pretoria. So we have our own unique challenges as a third world country, mostly having no power these days. So conflict of interests, I've worked with various companies, but mainly I'm really passionate about ECMO, and we are really growing our ECMO in South Africa. So let's quickly talk about bleeding. Bleeding is so common on ECMO, and it's one of the major problems that we deal with every day. And there's quite a few people in the audience that actually are going to talk about bleeding, and they are absolute world experts on it. So I'm just going to mention a few things. The hemostatic complications that we see, both bleeding, clotting, hemolysis, thrombocytopenia, heat, different anticoagulants we can use, how to monitor it, and maybe if there's time, a little bit on the transfusions. The indications, like all talks on ECMO, if your lungs looks like this, you go on to ECMO for BV ECMO, and if your heart looks like this, you're going to be a ECMO. So and this is the person who this heart belongs to. Last weekend, she did a 48 hour challenge where they ran every 4 hours for 48 hours. So they can completely recover, which is fantastic. So, as we said, any cardiac disease and any respiratory disease, for the right indication, please go onto ECMO. And we're doing quite a bit of ECPR these days with its own unique challenges with bleeding, especially if they're hypothermic. And it's all about the balance between delivery and consumption. Yeah, I found this very, very nice article on major bleeding in adults undergoing peripheral extracorporeal membrane oxygenation, predictors and prognosis. So it's really small, so you can't see. But in the end, there's not much difference between the guys who bled and those that did not. So not in terms of age, sex, the indications for going on to ECMO. So the incidence was still around 31.4% of major bleeds in this group. And we know that the in-hospital mortality, the adjusted hazard ratio, then goes to 3.56. The only two things that they could find in this large study was that if your APTT is more than 72 seconds and your fibrinogen drops to below 2, which often happens in my patients when they're on long ECMOs, then you're at an increased risk of having a major bleed. And we know that it's a disaster. We just had a very, very good talk on the neurological complications. So they did a retrospective study where they looked at autopsy results of patients on ECMO, and we know that they say up to 97% of had hemorrhage in at least one organ system, and around 57 had thrombosis in at least one organ system. From the same article, you can see external bleeding is the main problem. Hematuria, GI bleeds, abdominal bleeds, pneumothorax, and then external bleeding is the main problem. External bleeding we manage with topical manners. So, but what we see a lot is GIT bleeds, maybe because we do lots of ECMOs for PJP pneumonia, and they often have CMV as well. And I think that's the reason we see a lot more GIT bleeds. So ECMO is all about the balance, the clot and the bleed. So, and we know it's all about the blood surface interval where you have protein absorption. You get then the fibrinogen attaching to the surface, platelet adhesion, or fibrin and thrombin formation with platelet activation and consumption, and then you have a clot. So that's why we give the heparin in the first place. So, but it's also about the hyperinflammatory response of these patients on ECMO and what it does to the whole endothelial system. So you have activation of your neutrophils and the platelets, and you get hyperoxemia and reactive oxygen species. So the whole pathophysiology all leads to the bleeding and or the clotting. So bleeding, most often from the incision sites, intracranial is always a disaster, hematuria and GIT bleeds, and then clot formation, as we all know, mostly in your ECMO circuit, on your cannulas, but also DVTs and ischemic strokes. So again, we all know that virtuous triad of the etiology of thrombosis, with the procoagulant surface of the circuit. So, and that's your part of your endothelial injury. So we give an anticoagulant and we make them hypercoagulable. And there's also high consumption of your coagulant factors, and you have abnormal blood flow, immobilization, turbulence, and slow blood flow. So the most common reasons they bleed is the coagulation factor deficiency, including the fibrinogen and factor 13, thrombocytopenia or platelet dysfunction. I think we underestimate the effect of the platelet dysfunction, even if your platelet number is okay. Overdose of your anticoagulant, we just mentioned that you should aim for a lower PTT. Acquired von Willebrand syndrome, hyperfibrinolysis, and then anatomical cause. We recently had a 10-year-old on ECMO where she had a large hematoma around the insertion site of her one cannula, which later on went on to cause an abscess. So anatomical causes is really important, and you must work closely with your surgeons to try and have optimal incisions. Nice summary of why they bleed and why they clot. So, in our experience after doing ECMO since 29, is that yes, the circuit, yes, the oxygenator, yes, the pump, everything contributes, low flow zones, but what we see is the patients. They bleed because of the underlying disease. They bleed because they get a DIC. So they bleed because they have liver dysfunction. So yes, the major thing for bleeding, what we see is they bleed because of the disease. We know that the incidence of acquired coagulation disorders in the first 7 days of ECMO is high, especially factor 13 deficiency and acquired von Willebrand. I like to say red cells hate the circuit and the circuit hates the red cells. So yes, you do see some hemolysis. Depending on your circuit configuration, whether you have appropriate size cannulas, you can have less hemolysis. So usually the rate of hemolysis is under control and your free hemoglobin is less than 0.1 gram per deciliter. So, but if venous access is a problem, then high suction will cause more hemolysis. Look out for the hemoglobinuria and monitor the plasma hemoglobin level. So, and it can be due to clots that you can't see or a cannula malposition. And we know that free hemoglobin will decrease your nitric oxide, which is so crucial. It causes renal failure, GI dystonia and pain, systemic and pulmonary hypertension. So, and we know that free hemoglobin also increases your von Willebrand factor mediated platelet adhesion. So, really important not to look out for that hemolysis. And we know that plasma free hemoglobin is an independent predictor of mortality among patients on ECMO. And there you can see, so if you don't have any plasma-free hemoglobin versus, and this is up to 30 days. So mortality is dramatically increased. Thrombocytopenia, we all know that the platelets drop on ECMO. So what we found in our population is that if the patient is septic, the platelets are low. It's not necessarily always the ECMO. It's rare. 0.3 to 3% of all ECMO runs. You can change your anticoagulant or run no anticoagulant if you can. So it's all about balancing hemostasis during ECMO. So balancing the activation on the artificial surface, but in the same time managing your with transfusions, replacement of specific factors, and monitoring and adjustment of your anticoagulant levels, or replace your circuit if you need to. So, as we said, most of the bleeds are local bleeds. So use topical agents if you can, and then you can also increase your platelet or fibrinogen targets. Use systemic antifibrinolytics, which we don't like to use on ECMO because we've had some very bad clotting situations, or you can use Villibran factor concentrates or recombinant. Okay, so I'm going to just quickly go through this. So heparin is still the mainstay of our anticoagulants. We all know how it works. Have a protocol to work with. So whatever your protocol is, if it works for you, that's fine. So we work on APTT ratios, and it also mentions how often you should check your PPT. Valerudin, so we can use that instead of heparin. We all know how that works. There's lots of alternatives. We have run ECMOs without heparin or any anticoagulation for prolonged periods of time. So we have patients with pulmonary bleeds, trauma patients, patients with intracranial bleeds. So you stop the anticoagulation and you monitor the patient. Treat the patient, not the numbers. So just a nice article on nitric oxide as a novel anticoagulant. So in future, I think that's what we're going to do. Monitoring, we all know that people use either ACT, PTT, or anti-10A. We prefer using PTT as our mode of monitoring. I'm not going to go through this, we're running out of time. So we know that anti-10A there correlates very well with your dose of heparin, so PTT as well, but the ACT at low dose heparin does not correlate as well. So let's skip this. TEG, we do daily TEGs and we respond appropriately to that. Okay, so according to all the literature, anti-factor 10A is the most sensitive test for heparin monitoring, but it can be falsely low in the presence of high plasma-free hemoglobin and bilirubin, and that's the patients that's going to bleed. So you must be aware of this. So if you have a patient with a low anti-10A and he's bleeding, then it might be because of the high plasma-free hemoglobin. Okay, so let's not talk about this. I'm going to skip through all of this. Okay, so in our situation, I do not think that bleeding is inevitable on ECMO. So we know how to manage bleeding on ECMO. We know that we can transfuse all the different components, and it's all about meticulous attention to detail. And that's our slogan in our ECMO unit, is meticulous attention to detail. Because if you monitor and you measure, so you can manage the bleeding. Yes, about 33% of patients will suffer a major bleed, but not all of them. So it's not inevitable. You must manage the patient. And I want to invite you all to the 19th International Congress of Cardiothoracic and Vascular Anesthesia. We're going to run a whole ECMO, 2-day ECMO workshop as a parallel session. It's in Cape Town, beautiful Cape Town, and it's end of the year, 13th of November to the 2nd of December. Thank you for your time.
At the outset, I congratulate and thank both the speakers for their excellent presentation. Both of them have covered every minute aspect of their topic within a allotted time. Congratulations. Now, House is open for discussions, comments, or compliments.
I just want to, one question to Dr. Matthews. If you detect intracerebral hemorrhage during ECMO, so how do you go ahead? Do you stop the procedure? Does it depend on the size of the hemorrhage? Because that is one question that comes to our mind.
Yeah, and so it's a great and very tough question. I think so. If a hemorrhage is absolutely huge, then yes, size matters. But what I would say we do much of the time is stop the heparin. So let's stop any additional bleeding from occurring, and then try and wake the patient up. Let's see what they're doing. Because again, CT scans, MRIs are wonderful to tell you structure. They don't tell you anything about function. So let's wake them up and see what they look like. We've been able to manage some patients on ECMO with it. But with that being said, once you see that hemorrhage, the clock is ticking. You've got to get off anticoagulation, and you got to think about trying to get them off of ECMO sooner rather than later.
But at least one quick question to you. Sunil here. Hi. Just bleeding related to keeping the cannulas in for long term, cannula related bleeding, or bleeding related to cannula slipping off. How did you come across that, and what is your advice to the audience?
It has happened to us, unfortunately, where we had cannulas dislodging or partially dislodging. So that obviously immediately we need to, if it's completely dislodged, we need to replace. So unless the patient is ready to come off ECMO, or else we've had cases where we had a partial dislodgement, where not the right thing to do, but we pushed the cannula back and
so we do see bleeding around cannulas quite a lot. We use
local hemostatic agents like quick-clot, got a complicated name. You'll find it on the internet, which is a local hemostatic agent. And when we insert it, we put the quick-clots around the cannulas from the start with the dressing on, and we find that it works really well. That our surgeons are very experienced, so we don't have a lot of bleeding around the cannulas initially. If you have a patient on ECMO for 3 months, like we had recently, then the cannulas, after a while, they loose, they move, we do mobilize our patients, and then you have what we did is sedated the patient, we resutured and redressed everything like we would do for a new patient. But it happens a lot.
Thanks, Matt and Marlies, for your elegant lectures.
If there are no more questions, we conclude this session. Thank you very much.
Thank you so much, respected moderators and speakers, for sharing your valuable knowledge with us.